Now we're going to see the coartation of the aorta. Coartation of the aorta. We have the infantile form and the adult form. We have the aorta. We have the brachiocephalic trunk, right brachiocephalic trunk, left carotid, left subclavian, and all the way down. We have the communication between the aorta and the pulmonary artery is the, well, now we have the ductus arteriosus, that's the remnant we have here, the ductus arteriosus. This is the communication with the pulmonary artery. Alright. A coartation of the aorta could be before the ductus arteriosus, that would be proximal, or distal, after the conductus arteriosus. If we have it proximal, that is here in the infantile form, we have it here proximal to the conductus arteriosus. So we have here the coartation is this very stenosis. We have this stenosis of the aorta. It is here before or proximal to the ductus arteriosus. So the upper extremities are completely normal, they receive blood normal, but the inferior extremities, one, do not receive blood because, well, less blood because of this coartation, and two, because we have increased pressure in the pulmonary artery than in the aorta because of the coartation, and the coartation is before the ductus arteriosus. The gradient of pressure is increased in the pulmonary artery, so blood goes from the pulmonary artery to the aorta, and so the legs receive deoxygenated blood, and so we have cyanosis of the legs. This is going to present in a child that, for example, when exercises, gets very tired of the legs because it's receiving deoxygenated blood, not oxygenated blood, and now that it's exercising, well, more oxygenated blood needs, and we have less. This is the infantile form and presents in young children, usually like could be 3, 8, 11 years, and is associated with Turner syndrome, so it's associated with women, but also boys, yes, obviously, just in the association with Turner syndrome. Next, in the adult form, we have again the aorta, brachiocephalic trunk, carotid, left carotid, subclavian, and the conductus arteriosus. Here the stenosis is postductal. So we have it here. This is it's postductal. So we have the coartation. Yes, the coartation is postductal. So the gradient is normal between the aorta and the pulmonary artery. It is greater in the aorta. Here is the pulmonary artery. It's greater in the aorta because here we don't have yet the coartation. But the legs are receiving less blood because we have this coartation. No deoxygenated blood because the coartation is after. And so we don't have that gradient of pressure that was reversed here. No, we here just have we have less blood to the legs, but we have collateral circulation, that is some branches of the aorta that give the intercostal arteries communicate with arteries of the at the end of the leg. So these arteries pull more blood from the aorta, and that blood that they receive extra gives to the legs. So we have engorged intercostal arteries, and this in the ribs. Well, here this is the rib, and here is the intercostal artery. It's normal, but now it is engorged because it's pulling more blood that is going to give to the legs. so we have engorged the artery, and it looks like notching of the ribs. This is in the adult form. In the adult form, so is a coartation of the aorta that is postductal, and in the infantile form is preductal. These patients also have increased risk of rupture of berry aneurysm. This is not that they have increased risk of berry aneurysm, no, just that if they have a berry aneurysm, it is higher the probability that rupture, because we have coartation of the aorta that increases the pressure backward to the coartation. So we have increased pressure in the head, in the upper extremities, but in the head, and so we have increased pressure, risk of rupture. And the other thing is this is also associated with hypertrophic cardiomyopathy.